Hello and welcome to the BSAVA Science webinar, taking a closer look at some of the papers published in the Journal of Small Animal Practice. I'm Luisa Dormer, Scientific Editor at the BSAVA, and today I'm joined by Nicola Di Girolamo and Kieran Borgeat to discuss the paper Long-Term Biological Variability and the Generation of a New Reference Interval for Plasma N-terminal pro-B-type natriuretic peptide in Labrador retrievers. Nicola is an Associate Professor in the Department of Veterinary Clinical Sciences at Oklahoma State University and is Editor-in-Chief of the Journal of Small Animal Practice. Kieran is a Senior Clinician in Cardiology at Langford Vets, University of Bristol, and an American and European diplomat and our CVS Recognised Specialist in Veterinary Cardiology. Welcome to both of you. Thank you for joining me today.
Thanks very much.
Thank you.
So Kieran, I wondered whether in the first instance you could tell us what N-terminal prohormone of B-type natriuretic peptide is.
So it's not the easiest thing to say, so we abbreviate it to NT-proBNP, which is a relief. We have too many abbreviations in cardiology already. But NT-proBNP is a peptide that's part of a larger molecule, which is easier to measure than the active hormone. The active hormone we're considering is BNP, or a B-type natriuretic peptide. And this is a hormone that is released by the myocardium, atrial and ventricular, and also some other cells to a lesser degree. But it combats the effects of the renin-angiotensin-aldosterone system. So we think of NT-proBNP as increasing when there's excessive stretch or stress on the heart. So when the heart is stretched by volume loading in RAS activation, then this leads to an increase in NT-proBNP. So we know from numerous previous studies in dogs and cats and humans, of course, that NT-proBNP increases proportionately with worsening heart disease or degree of severity of heart disease. So therefore, it's often used in dogs and cats as a screening tool to see if there's heart disease in apparently healthy or asymptomatic patients.
Great, thanks.
So Kieran, could you tell us a little bit more about why you wanted to investigate the biological variability and actually generate a new reference interval for plasma NT-proBNP in Labrador retrievers specifically?
Yeah, it's interesting. There are a few studies out there that suggest there's significant biological variability in NT-proBNP. And I think Randolph Winter and a number of other colleagues of his have looked at some variability over a 2-3 week period in a group of dogs of different breeds. And they reported that there was up to 50% variability at just measuring the blood samples at different timeframes within that period. So clearly there's a lot of changeable things happening in the body that influence the NT-proBNP level, even in normal animals. And because that was quite a range of breeds, you know, large breeds, small breeds, high level of heart disease, lower level of heart disease, that made it quite a heterogeneous population to look at, which may have been associated with some of that variability or may have caused some of that variability. So I was quite interested in this anyway. And in addition, various different breeds have been shown to have a different median NT-proBNP. So there's one nice study out of Scandinavia where they looked at data from a reference laboratory, and they looked at circulating NT-proBNP concentration in different breeds, and they found that Labradors, Newfoundlands, Dobermans had higher NT-proBNP, and animals like breeds like Cavaliers, miniature dachshunds, I think, and boxers all had lower NT-proBNP on average. So this means that the laboratory reference interval, which previously was up to 900 picomoles per litre, may not have worked very well for different breeds. So this was the background in the literature. And myself and some colleagues made the observation over the last few years that we see a number of Labradors referred because of an increased NT-proBNP, so a measurement over 900 picomoles per litre, and those dogs were referred and actually were clinically normal and had normal echo, and other testing for cardiac disease was all negative. So we wondered if Labradors particularly had higher NT-proBNP. And I found myself in a situation where I was working with some colleagues at the Waltham Centre for Pet Nutrition and scanning a large cohort of Labrador retrievers. And as part of another study that they were performing, those Labradors would have bloods taken and NT-proBNP measured. So it seemed like a good opportunity to collaborate and look at the biologic variability in Labradors particularly. And what was quite nice about that population of dogs is they're not only one breed of dog who commonly are referred for cardiac evaluation, but also they're quite a homogeneous population. So these are dogs who are fed to maintain ideal body condition. They are fed the same diet. They're monitored over a long period of time anyway for their weight and well-being. They have the same housing, the same exercise regime. So it seemed like quite a nice way of eliminating some of those external factors that could influence the variability.
Thank you.
Yeah, thank you. So could you tell us a little bit more then about what you did and what you found in your research?
Yeah, we sort of began with this idea of just seeing, you know, is there biologic variability? But then we realized that from the data we had, or rather the data we were planning on gathering, we may be able to actually generate a breed-specific reference interval. And because of this previous paper looking at breed variability, we felt that would be a clinically meaningful thing to do that may help vets in practice to decide whether Labradors who apparently were healthy did in fact have underlying heart disease. So there were sort of two arms to the study. The first part of the study is the prospective collection of the NT-proBNP and the echo data for these healthy Labradors at the Waltham Centre. And we statistically evaluated the variability in those dogs over time and used those dogs to generate the reference interval. Then the second part of the study is a validation cohort or a validation period within the study. And this validation period is quite different. It's retrospective, and we looked at Labradors who'd been referred to see cardiologists with a proBNP that was high, or sorry, that was measured, not necessarily high, but they had a definite diagnosis from a cardiology diplomat. So we could then compare within that group the normals, the abnormals, and use that to sort of test our reference interval to see if it was robust or meaningful. So the first part we called a derivation cohort or a prospective cohort, and the second part we called the validation cohort. So in the derivation part of the study, we began with 62 Labradors that were available for potential inclusion in the study. And at the Waltham Centre, it was quite eye-opening for me actually. I hadn't worked with them before. They all underwent training for the echo. So they learned to walk up onto a platform, lie down voluntarily, and then they were just moved into the correct position and we did the echo. So these dogs consented, if you like, to being minimally restrained for their scan. And they walked off the other side, walked back on a little set of steps and lay on the other side for their second part of the echo. They were also habituated and trained to blood sampling procedures as part of this other study. And this is part of their very high welfare standard that they really didn't want to stress these animals in doing research. So these dogs were all very nice and calm. But during that process of training, there were 10 dogs where the trainers said, this dog's showing aversive behavior, we're not comfortable, they can be included. So that knocked 10 dogs out of the study. So we had 52 dogs left, but 52 happy dogs. So the dogs all underwent a full echo first. That I did both sides of the chest as standard, simultaneous ECG monitoring. And then that was at time point 0. Then they had blood samples taken at time point 0, and then every 2 months for a total of 8 months. So there were a total of 5 blood samples taken over the course of the study. So this is a nice long-term variability, which was quite an attractive thing for us studying it. And we got the data at the end of the study, and we did an initial analysis using a statistical method to identify any dogs that were particularly different to the rest of the group, that perhaps had some other factor that may have altered their NT-proBNP. And we found, using that Tukey method to look for outliers, one dog was statistically flagged as being different to the others. So although that dog had no changes on the echo, nothing in clinical signs, we excluded that dog from the study. So that gave us 51 dogs which were included. So what was super interesting to me was that almost 65% of those dogs, at least at one time point in the study, exceeded the current lab reference interval, that limit of 900 picomoles per litre. So that means 65% of dogs, if they were taken at their sort of maximum, or at a random time point in the study, they would have tested positive, if you like, for heart disease, and therefore undergone further testing that maybe wasn't necessary. So that was quite an interesting thing. Thinking about the variability, we looked at two measures of variability. So the first one we looked at is called the coefficient of variation for the individual. Now what that does is it compares the individual dog at the different time points in the study, and it says how variable is this individual over time. The second coefficient of variation that we looked at was the group coefficient of variation. So that's the mean variability between dogs at each time point, to see what the sort of how the individual compares to the group rather than how the individual compares to themselves. The other thing we did was look at something called the Index of Individuality. And the Index of Individuality involves those two variability coefficients, and we'll come back to that in just a second. So the first results we got suggested that the individual variability, so how much a dog changes month on month, is around about 20%. So we got 19% variability, which means if you're measuring one dog over time in clinical practice, you'd have to have at least a 20% change in a Labrador for that to be a real change outside of that random biologic variability. The coefficient of variability for the group was much higher, which means that the span of measurements in normal dogs in the whole population is much greater than the individual. So that was about 43%. So it means that, you know, within that reference interval, there's a huge amount of variability that we would call normal. So thinking about this Index of Individuality, that's a measurement that tells us how useful it is to monitor an individual over time versus comparing a single measurement against a reference interval. So tests that have got a low Index of Individuality, and the statisticians define low as less than 0.6, that means that their individual variability is lower than the group variability significantly. So therefore, change in that individual might be masked by the overall group variability. So in our cohort of Labradors, we found the Index of Individuality for NT-proBNP was 0.44, which means that actually, although we are talking about reference intervals in this paper, the reference interval is not that useful for an individual dog. It's useful for a population, but for an individual is not useful. So if you have a particularly high-risk dog, maybe a family history or something, then monitoring trends over time may be stronger than comparing it to a reference interval. The problem is that doing that for all dogs to screen for heart disease is pretty impractical. If we said for every dog where we wanted to screen for heart disease, we had to test them 3 times over 2 months, actually most owners aren't going to go in for that. And we're not going to be able to screen one dog who has mild clinical signs on a given day to look for heart disease. So it's quite a difficult thing to do, I think, in real life. So we calculated the reference interval for this group of dogs, and the reference interval for the population was 275 up to 2,100 picomoles per litre, which is very different to the lab recommendation of 900, which is largely calculated using Dobermans and other breeds like that. So this, I think, explains to me why, in our experience as cardiologists, we see lots of Labradors that are referred for workup because of a high proBNP, but actually it might be normal for them or for that breed. So our limit went up to 2,100. So we wanted to try and put this limit through its paces and test that limit a little bit to see if we had calculated it correctly. Did it make sense? So we used the validation cohort for that, which is where we retrospectively recruited dogs from 4 UK-based cardiology referral centres. And the numbers in this bit are pretty small. So we've got 14 normal dogs here. We've got 11 dogs with dilated cardiomyopathy, 4 dogs with arrhythmias. One was third-degree AV block, one was a supraventricular tachycardia, and some others. And there were 5 dogs with other diseases, one of which was congenital. And I highlight that just because my belief is that congenital disease doesn't tend to increase NT-proBNP very high. So, you know, the main interest there for me is the 14 dogs who are normal, healthy dogs with normal echoes, and 11 dogs with dilated cardiomyopathy. So in the normal group, when we measured that NT-proBNP or looked at that NT-proBNP, we found that 13 of 14 were within the normal reference that we had calculated. So that suggests that chances are it's a useful reference interval for identifying normal. And in the DCM group, 9 of 11 exceeded the upper limit of 2,100. The other 2 were very close, but they were still within that 2,100 reference limit that we calculated. So when we calculate the performance of this test in this population of retrospective dogs using a limit of 2,100, it suggested that the positive predictive value was 90% and the negative predictive value was 87% for identifying DCM. So I think these are clinically meaningful things, and you know, although the test isn't perfect, even with this reference interval, it's probably stronger, or well, definitely stronger than using a cutoff of 900.
Great, thank you for that very comprehensive outline. So in the manuscript, you suggest that screening using plasma NT-proBNP measurement is an attractive proposition for vets in general practice in order to prevent them from having to perform an echo in every at-risk dog. Could you tell us a little bit more about the test? Are we in a position where this is already or could potentially be widely used?
So, yeah, I think NT-proBNP has been widely used for a long time. I remember the test being advertised first maybe 2003, 2004. And at that time, we didn't know what the reference interval for any dog was really, or particularly how to handle samples. And a lot of research from groups in London at the RVC, and also groups in Germany and the US, showed how best to handle the samples and how to interpret those. So it was quite an evolution of our understanding of this test back then when it first came out. So it's available from a number of reference laboratories, and in cats there are even a SNAP in-house ELISA test which is available. So it's a very accessible test. It's generally cheaper than an echo, certainly in the UK, and most countries in Europe and the US. It's a lot cheaper than an echo, and it's very accessible, and the assay is fairly stable now. So it's quite easy for vets to take a blood sample for this, you know, spin it down, stick it in the post, gets to the lab a day or two later, and actually the results that the lab get are pretty reflective of what it would have been if it was taken on ice and sent immediately by courier. So it's quite an accessible, useful test. We used IDEX in our study simply because they're quite commonly used. Some of the other reference labs send it to IDEX, and they've got quite a long-standing assay which has been updated. So we went with them because we felt it was reflective of what a lot of vets would do. And as I sort of suggested before, lots of vets are already using proBNP as a screening tool in apparently healthy dogs to look for cardiac disease, DCM particularly. And a few years ago, a pharmaceutical company offered some free testing, which kind of got vets in the habit of doing that, looking for DCM in these larger breed dogs. So because of all these different factors, this kind of familiarity and availability, I think it could be a really good screening tool for heart disease, but obviously we've got to use it in the right context, and also we've got to use it compared to the right references from the lab. So I think there has been a bit of a perception from vets who have used this quite a lot that potentially they've got results back that say the proBNP is 1,500, say, in AN of the dog, which exceeds the 900 cutoff, and therefore further investigation should be done. And the dog undergoes further investigation and everything's found to be normal. The vet maybe feels a bit anticlimax with that, although obviously it's good for the dog, but they may feel, well, I'm not so sure the test was useful for me. And owners, of course, or breeders of dogs may come back and go, oh, hang on a minute, you know, we spent money on the test, then we spent lots of more money, and actually the test wasn't really accurate. So I think there's been a little bit of a loss of confidence in it recently. And I would hope that this paper contributes a little bit more to people's confidence in using the test in Labradors, because at least we've got a bit more of an accurate picture in that breed of how to interpret those test results.
I suppose then, picking up on your last point a little bit more, what are your thoughts on using this measurement if, for example, you had a patient that you suspect of having DCM, but it's not a breed that is typically considered predisposed to the disease?
That's a super question, because obviously a test is only as good as the decision making that goes into it, if you like. So when we're thinking about clinical utility of the test, you've got to think about prevalence of disease as well. So what's the pre-test probability? What's the likelihood an animal has a disease that's making you run that test? So if you run any test in a patient that's got a very low prevalence of disease, but you get a positive result, it's probably an inaccurate result. So there'll be more false positives, if you like. My favorite example, which was given to me by one of my mentors during my residency, was imagine running a test for heartworm antigen for diarrhea in a dog that lives in isolation in Aberdeen, in Scotland, where heartworm is not endemic and there are no cases in non-travelled dogs. Well, if the test comes back positive for diarrhea antigen, the vast majority of vets are going to look at that and say, well, that's a false positive, clearly, because it's so unlikely this dog has the disease in the first place. So I quite like that as a starting point for thinking about how prevalence influences test result. So if we flip that around and say, with NT-proBNP, if we look for DCM in an apparently healthy 2-year-old Alaskan Malamute, who have a very low prevalence of dilated cardiomyopathy, they're fed a complete commercial diet, it's not grain-free, there's no family history of DCM, normal exercise tolerance, performing well, pulling sleds maybe, who knows. Then actually we run the test and we get a high number back, it's probably that individual dog has a false positive. So maybe has a spike in circulation for some reason on that day, because it's a Thursday, because of normal biologic variability, or maybe the assay didn't run properly at the lab and something like that. So both those eventualities are probably more likely than the dog actually having DCM. So I think, for your example of a non-predisposed breed, it's a little different if they've got a family history where maybe the mother dropped dead age 7, this dog is 6 that you're seeing, and you treated that dog's father for heart failure signs. Okay, there's a strong family history there of potential cardiomyopathy. So that dog, irrespective of breed, merits testing, and the test results should be taken seriously. But if you have a patient that's got absolutely zero history in the family as far as you know, they're maybe a little bit younger because DCM tends to come in middle to older age, and they're an underrepresented breed, then it would be something where I would question the utility of that test. And maybe if you want to go for the gold standard, if the owner's very concerned or the breeder's very concerned for some reason, potentially a blood test like NT-proBNP isn't the right thing to do, and maybe an echo which tells you what the function's like and shows you the structure of the heart would be the better test to do in those circumstances.
Great, thank you.
Thank you. So we know that screening procedures can be also kind of dangerous because of the risk of overdiagnosis of certain diseases or certain conditions.
Sure.
So I was wondering, what do you think are the risks actually associated with overdiagnosis, if any, or how would you address this for our colleagues that are listening to us?
I genuinely believe that overdiagnosis is a problem, and I've spoken to some vets, some practitioners who would say, well, what's the worst that can happen if we run a blood test and it comes back high and the owner says, I don't want to do anything else, I just want to give him some treatment. Well, in this scenario, if a dog did have occult preclinical dilated cardiomyopathy, then treatment is indicated and proven to be beneficial. So treatment with pimabendin has been shown by the PROTECT trial back in 2012 to benefit dogs with DCM, prolong life, reduce progression of disease. So in this circumstance, many practitioners might just reach for the pimabendin and say, well, you know what, don't bother having a referral, or don't bother having my colleague do the echo or whatever. Let's just treat. What's the worst that can happen? It's a safe drug. I would argue that obviously no drug is perfectly safe. There's always the potential for adverse events associated with drug use. We've seen a few dogs develop on pimabendin some gastrointestinal signs, and often they have a history of dietary sensitivity. So there's something in the flavoring of the tablets there that can affect them potentially. That's not so much my bother. My worry is how people think of that patient when they're given a diagnosis. So imagine if you have a patient who's been given a diagnosis of DCM last year, and they're on pimabendin, no adverse reaction, the owner's comfortable with the monthly cost of the drug, they're just ticking away, but actually they don't have disease, they're just fine. 6 months down the line, the dog starts developing a mass lesion, and you as the clinician, as the vet in practice, say, well, actually, I'd recommend we remove the mass. Ooh, but he's got heart disease, and therefore he might be a higher risk for anesthesia. That's a problem to me, because suddenly we're making decisions about the well-being of the dog. Maybe we delay the surgery, maybe we never do the surgery at all, and the dog would benefit from the surgery and never should have been prevented from having it. So I'm a great believer that overdiagnosis is more of a problem for how we think about the patient and how the owner perceives the patient. Maybe feeding them more, maybe they become obese, and obviously all the health problems that entails, rather than just the treatment. And the cost and things. I think it's the psychology of it is a much bigger problem. How we change that is a much more difficult part of that question. I think, first of all, having a better confidence in our tests, hopefully because of our data, not that it will change the world, but just that it might make a little contribution to people's confidence in a diagnostic test in that breed. I think that will help. And I think if vets know when to test and what the risk factors for disease are, such as family history, exercise intolerance, things like that, for these very early signs, then actually maybe vets will be more confident to say to an owner, we should test and we should screen to try and do that. And then when we get a positive test result back, we should also remember it's biology and biochemistry in the lab. It's not perfect, and therefore it may be a false positive or a false negative. So we've got to think about the context of it. If we get a positive, we should perform an echo in this scenario rather than just saying, tell you what, let's just give them the pimobendan. That's probably the wrong thing to do.
Thank you very much. Yeah. So a very good thing of your study is that it included both healthy and also affected animals. I wonder how what is the effect of including affected animals in studies, since in veterinary medicine we see most reference interval studies just including healthy animals.
Yeah, thank you. We think that's, or thought in designing this study, that was pretty essential, not just to derive what the numbers are for that reference interval in an apparently healthy group of dogs or a group of healthy dogs, but also to challenge that by testing it in a different population. And I've seen some papers do that before. We're not the first people to do this, and I really liked that. I just thought it made something that was sort of statistical and potentially a bit removed from the clinic. It brought it really to the clinic floor, and it really spoke to me as a clinician. So, I think our two different arms of the study are quite a good example of how to do that, but also the potential pitfalls of not doing it. So our group of in the derivation cohort of the Labradors that were healthy, they were the same breed, they were fed to maintain ideal body condition score, they had the same exercise regime, the blood samples were taken at the same time of day within a 2-hour window. So they were very homogeneous, much more homogeneous than real life. So we've derived our reference interval here, and actually if we didn't challenge that reference interval and test it, then it might be that we were misrepresenting things. So in testing the reference interval, I think that it makes it more meaningful for people how to interpret those results. And for me, that meaningful interpretation there is the positive predictive value and the negative predictive value, which tells you how that test performs. So that's quite different to sensitivity and specificity, which are often quoted in publications of diagnostic tests. And obviously that they are meaningful, they're useful figures. But to me as a clinician, the sensitivity and specificity tell you how the test performs in animals that are diseased and not diseased. But if we look at it slightly differently, if you've got a patient in front of you, you don't know the disease status, and you get a positive test, the likelihood of that patient having a disease in the light of a positive test is the positive predictive value, not the sensitivity or specificity. So to me as a clinician, that's what I see. I see a test result, I see an animal, and I want to know if they have disease or not. So to me, the positive predictive value and negative predictive value are much more useful. So, for example, if you have a test with a positive predictive value of 50%, well, if you have a positive test result, you might as well have flipped a coin to check if that dog has the particular disease you're testing for. So in our cohort, when we tested it using these, the mix of healthy and unhealthy Labradors, that showed approximately a 90% positive predictive value and a 90% negative predictive value, which means 9 out of 10 times that population, that test will be correct, positive or negative. So that's pretty good. I'm happy with that. But we have to remember that those values, the positive predictive value, negative predictive value, rely upon the prevalence of disease, which takes us back to your question about looking at this disease in an atypical breed, for example, or a low-risk individual. The prevalence may be much lower in those dogs, and therefore, of course, the utility of the test will be different. So the prevalence of DCM in our study was about 45%. So actually, if we take that to practice, you've got to think about how old the dog is, what the family history is, other risk factors, to get a similar prevalence to mean the test will perform as well.
Thank you very much. Yeah. So I think we have time for our last question, Luisa. Okay, great. So what do you suggest in case an animal is showing an upward trend over time, but these measurements still remain inside the reference interval? Should they go further with additional diagnostics, or what would be your indications for that?
Yeah, the short answer is yes. An upward trend over time probably is very significant in NT-proBNP. So this comes down to that test or that result, the Index of Individuality. If the Index of Individuality is less than 0.6, ours was 0.44, then the upward trend is probably more important than a reference interval. It's just that practically measuring multiple samples over a short period of time is challenging, I think. So this is probably not just true in Labradors. Randolph Winter published a few years ago, and he also reported that an NT-proBNP across numerous breeds of dog also had a low index of individuality. So it seems like this monitoring of trends is super useful. I think the ones to do it in, the cases to select in whom to do these multiple testing is probably family history, as I said, or maybe in breeding dogs, especially the males. The stud dogs can father hundreds of puppies over a year, and actually if they're having multiple proBNP testing, it may be useful for detecting early disease without a high level of intervention on a tighter budget. The other situation might be if you echo a dog and you find equivocal findings. It may be the dog's quite athletic, but it may be that if you monitor NT-proBNP, you see it creeping up, even if it's still within the reference interval. That is important. Based on the biologic variability of the individual from our data, we would suggest that the change would have to be 20% or more to be a true change, rather than just random day-to-day variability of an individual dog.
Great.
Thank you very much.
Thank you both so much for giving up your time today to discuss the paper, and thank you for listening. As a reminder, the full version of this paper can be found in the June 2020 issue of the Journal of Small Animal Practice, and a link can be found in the comments below the recording. Join us next time when we will be discussing the paper Retrospective Characterization and Outcome of Canine Idiopathic Mesenteric Purulent Lymphadenitis and Lymph Node Abscesses at a Teaching Hospital from 2005 to 2015.